Welcome to the Deep Dive, where we unpack complex topics, distill the most important knowledge, and hopefully equip you with insights to navigate the world a bit better. Today, we're embarking on what feels like a deeply personal and incredibly vital journey. We're looking at understanding and managing cancer treatment side effects. And specifically, we're focusing on a population that's rapidly growing within oncology adults over 65.
Yeah, it's a really important demographic to focus on.
It is. And the reality is, while cancer treatment offers these amazing life-saving possibilities, it also presents pretty significant hurdles. And for older patients, these challenges, well, they often get magnified. It layers complexity onto what's already a really demanding situation.
Yeah.
I mean, just imagine someone trying to navigate chemotherapy while also managing, say, longstanding heart disease, or maybe diabetes, or perhaps arthritis.
Right, comorbidities.
Exactly, the comorbidities. They're often dealing with multiple pre-existing health conditions, and they might also be on several different medications already.
Polypharmacy, yeah.
Polypharmacy, where each drug can potentially interact with another or, with the cancer treatment itself. It gets complicated fast.
It really does. And then you add in the age factor itself.
Right. And that natural decline in, physiological reserve, meaning their bodies just have less buffer to withstand the rigors of therapy.
Precisely. Less resilience in a way.
So for this group, side effects aren't just like uncomfortable annoyances. They can fundamentally threaten their independence, their ability to function day to day, and critically, their capacity to even continue the very treatments that could save their lives.
Which is a devastating possibility.
Absolutely. So our mission in this deep dive is pretty clear. We want to explore how patients, caregivers, and healthcare providers can proactively collaborate, really partner up, to manage these treatment side effects.
Mm-hmm.
The ultimate goal isn't just about getting rid of the cancer, right? It's about preserving function, maintaining a good quality of life throughout the whole journey.
Yeah.
Because for so many people, life becomes about living with cancer, not just surviving it.
That's such a powerful distinction, and it really highlights a critical shift happening in modern medicine, particularly in geriatric oncology. It's not solely about targeting malignant cells anymore. I mean, that's crucial, of course.
Sure.
But it's also about embracing a much more holistic approach,
Right.
where the focus really extends to preserving the entire person. We're talking their physical function, their cognitive clarity, their emotional well-being, their dignity. It's the whole picture.
Protecting the quality of life itself.
Exactly. Ensuring that these life-extending treatments don't inadvertently diminish the very quality of life they're aiming to protect. So this deep dive, we're going to illuminate this by focusing on four particularly common and really consequential side effects.
Okay.
We'll look at nausea and vomiting, core appetite and weight loss, that debilitating fatigue we hear so much about, and neuropathy-induced gait impairment, basically. Trouble walking because of nerve damage.
Got it.
These are all areas where, honestly, thoughtful, proactive, and collaborative effort can make an extraordinary difference, empowering you, the listener, and your loved ones to navigate this journey much more effectively. Nausea and vomiting, a preventable distress.
Okay, let's unpack that first significant challenge then.
Yeah.
Nausea and vomiting. It feels like we've made huge strides here. Modern antiemetics, those anti-nausea medications seem so much better now. They've dramatically reduced chemotherapy-induced nausea and vomiting, CINV, right?
That's true. The advances have been remarkable.
Yet, despite all that, it still remains a major concern, especially, it seems, for older adults. Why is that? What makes them more vulnerable?
It's a really intriguing aspect of pharmacology when you look at older adults. Basically, their bodies often have slower drug metabolism and clearance.
Okay, so things just hang around longer.
Pretty much. Medications, including the chemotherapy agents themselves, and even sometimes the anti-nausea drugs we prescribe, tend to linger in their systems for longer periods. Think of it like a less efficient filtration system, maybe.
Yeah.
For a younger person, a drug might be processed and eliminated relatively quickly. But for an older person, that same dose could accumulate. That leads to higher concentrations in the blood, and consequently, a greater susceptibility to side effects.
So even the anti-nausea meds could cause problems.
It's a bit of a paradox sometimes, yeah. The solution can become part of the problem if it's not meticulously managed, because those drugs can also linger longer and cause their own side effects. It's a constant tightrope walk for providers.
Wow.
And just to put this in perspective, this isn't a minor discomfort we're talking about.
Yeah.
Even with what we consider optimal prophylaxis to best preventive care. The prevalence of CINV with highly immunogenic chemotherapy That's the kind most likely to cause vomiting.
Right.
It can still reach a staggering 70 to 80%.
70 to 80, even with the best prevention.
Yes. Imagine being one of those patients. And furthermore, what's often underreported, especially in this demographic, is delayed CINV.
Delayed, so not right away.
Exactly. This isn't the immediate nausea that hits right after treatment. It's the kind that can, sneak up on patients more than 24 hours later, sometimes days after they've left the clinic.
That sounds awful. Disruptive.
Oh, incredibly disruptive. It messes with their daily routines, makes them hesitant to eat, affects social interactions, just generally erodes their quality of life long after the infusion is done. It can create this pervasive sense of dread about the next treatment.
Okay, so if prevention is so critical, what does this actually mean for providers? What proactive steps should they be taking?
Well, the provider's role here is absolutely paramount, and it really has to begin even before the first drop of chemotherapy is given.
Before treatment even starts?
Yes. It starts with a comprehensive geriatric assessment. And this isn't just like a quick checkup. It's a deep, detailed evaluation of the patient's overall health, looking specifically at their kidney and liver function.
Why those organs in particular?
Because they're the primary engines for metabolizing and clearing drugs from the body. If they aren't functioning optimally, which is often the case in older adults due to age or other health issues, then drug dosing needs to be meticulously adjusted to avoid that buildup we talked about. Precisely, to prevent excessive accumulation and consequently more severe side effects. The gold standard, without question, is prevention, not just reacting once someone feels sick.
Right.
And this commitment to prevention means prescribing a multi-drug prophylactic regimen before chemotherapy even begins.
Multi-drug. So not just one pill.
Usually not for the high-risk chemo, no.
Here.
We're talking about a sophisticated, coordinated attack on nausea from several angles, designed to block those signals before they even start. Think of it like a team. One type of drug, maybe a 5-HT3 receptor antagonist, blocks a specific pathway in the gut and brain. Another, an NK1 receptor antagonist, targets a different key pathway.
Okay.
And then often a corticosteroid is added, not just for inflammation, but it also has an extra anti-nausea effect. Giving these together preventatively as a carefully timed cocktail is way better than playing catch-up.
Profoundly more effective, yes.
But you mentioned even the anti-nausea drugs can cause side effects.
Yes, that's the other side of the coin. Providers have to be acutely aware of this. Some of these medications can cause sedation, which is a huge fall risk, right?
Definitely.
Or confusion, which can compromise safety and cognitive function. Or constipation, which, especially if they're on other meds causing it, can become a really big problem. Discomfort, gut issues, even hospitalizations.
Oh, it's a balancing act.
It truly is. Always weighing the huge benefit of preventing nausea against the potential harm of the preventive meds themselves. Another strategy, of course, is considering less immunogenic chemotherapy alternatives when it's clinically appropriate, if there's an option that's just as effective but less likely to cause nausea.
That's often the better choice for an older patient.
Often, yes. And finally, providers need to be ready to order 5E hydration proactively if someone's oral intake falters.
Just because dehydration can sneak up fast, very fast, especially in older, frailer patients. It can rapidly spiral into more serious issues. BR visits, hospital stays, major setbacks. 4V fluids are a simple intervention that can prevent a whole cascade of complications.
Okay, this is incredibly helpful. This is where your role as the listener and the role of your caregivers becomes absolutely pivotal then. You are like the front line of defense against the CINV. What practical, actionable steps can you take right there at home?
That's such a vital point. The caregiver's role here is just instrumental. They function as a proactive partner in managing these symptoms. One of the simplest yet most impactful things, meticulously ensuring medication adherence.
Taking the pills on time. Sounds basic.
It sounds basic, doesn't it? But its impact is huge. Many patients might think, understandably, oh, I'll just take the anti-nausea pill when I feel sick.
Right, reactively.
But with these prophylactic regimens, the timing is everything. Caregivers can use simple tools, pill organizers, alarms on phones, to remind the patient to take their anti-nausea pills on the prescribed schedule, not just when symptoms hit. This consistent anticipatory approach lets the meds build up and work effectively, like a shield.
That makes sense. Build the shield before the attack.
Exactly. And beyond medication, managing the patient's diet is key. It requires a gentle, persistent approach. Think small, frequent, bland meals. Large, heavy, or greasy foods can often trigger or worsen nausea on a sensitive stomach.
So like crackers and ginger ale.
Yeah, keep things like plain, dry crackers handy. Natural ginger chews are great too. Ginger is a well-known natural antiemetic. Clear carbonated beverages, maybe flat ginger ale or plain soda water, surprisingly comforting sometimes. They help get some liquids and calories in without overwhelming the system.
Even ice chips.
We've seen patients benefit from sucking on ice chips or frozen fruit pops, anything that helps. But maybe most critically, the caregiver needs to be a vigilant monitor, constantly observing for subtle signs of dehydration.
What should they look for?
These can be easy to miss in older adults. Look for things like unusual dizziness, a persistently dry mouth, or a noticeable decrease in urination. Less peeing than usual.
Okay, dizziness, dry mouth, less urination.
Right. These are urgent signals. They need to be reported to the oncology team immediately. Don't wait.
Why the urgency?
Because if allowed to progress, dehydration can lead to that rapid downward spiral we talked about, potentially an ER visit or hospitalization. That's exactly what we want to prevent, because hospital stays can really impact an older patient's independence and function. So that proactive communication with the care team, it can literally be life-saving and avert a crisis. For appetite and weight loss, combating frailty.
Okay, building on that proactive approach, let's shift to another profoundly dangerous challenge. Poor appetite and unintentional weight loss. This might not sound as immediately dramatic as, say, acute vomiting, but the long-term consequences can be even more severe, right? Undermining strength, ability to fight.
Absolutely. It's insidious, but incredibly damaging.
And the physiological reasons behind this heightened danger, they're pretty deep-rooted, aren't they? Older patients often start out with less muscle mass anyway.
Exactly. They often have a lower baseline muscle mass because of something called age-related sarcopenia.
Sarcopenia, that's the natural muscle loss with age.
Yes, the progressive loss of muscle mass, strength, and function as we get older. It's like starting a marathon with less fuel in the tank already. They just have less reserve to draw upon when faced with the huge metabolic demands of cancer and its treatment.
Less buffer again.
Less buffer, exactly. And that's where the real challenge hits, because cancer itself often introduces this phenomenon called cancer cachexia.
Cachexia. Okay, what's that?
It's not just weight loss from not eating enough. It's a severe accelerated muscle and fat wasting driven by the cancer itself and the body's inflammatory response to it.
Wow, so the cancer actively causes the wasting.
Yes. So when you combine that pre-existing sarcopenia with cancer cachexia, the patient can spiral very rapidly into a state of severe frailty. This dramatically increases their risk of infections, makes them less resilient to complications, and critically,
makes it hard to tolerate treatment.
Exactly. It can render them intolerant to the very life-saving treatments they need. If a patient becomes too weak, too frail, they might have to stop chemo or radiation. And that directly impacts their chances for remission, symptom control, even survival.
That's incredibly serious.
The statistics really underscore the urgency here. Significant unintentional weight loss affects over more than 50% of older patients with advanced cancer. And it's consistently identified as a powerful, independent predictor of poor outcomes.
So it's not just about how someone looks.
Not at all. It's not a cosmetic issue, not just a number on the scale. It's a profound marker of declining health, resilience, and often an indicator of the disease progressing. Which is why, for patients and caregivers listening, the mantra truly has to be making every bite count. Being incredibly intentional and strategic with every single thing consumed, aiming for maximum nutritional value.
Make every bite count. Okay, so let's unpack how care providers tackle this. You said early and aggressive intervention is key. What does that look like?
It is absolutely necessary. The standard practice now, or at least what should be standard practice, initiated right at diagnosis ideally, is a referral to an oncology specialized registered dietitian. This isn't a luxury add-on. It's a foundational part of good cancer care.
So a dietitian specializing in cancer patients.
Yes, their role is multifaceted and incredibly important. They start with a full nutritional assessment, looking at eating habits, preferences, any aversions. Crucially, they calculate precise protein and calorie needs, tailoring these to the patient's specific cancer treatment plan, and importantly, their other health issues. Diabetes, kidney disease, which might require specific dietary tweaks.
Right, the comorbidities again.
Exactly. And then they provide practical, individualized advice on how to actually meet those nutritional goals, translating the science into actionable strategies for the patient and caregiver.
Makes sense.
And beyond the dietitian, providers also need to aggressively manage other symptoms that get in the way of eating.
Like what?
Think about painful mouth sores, mucositis. That can make chewing or swallowing excruciating. Or altered taste, dysgeusia, where food tastes metallic or bland or just plain wrong. That completely kills appetite.
Oh, I've heard about that metallic taste.
It's very common and very off-putting. So, addressing these issues maybe with soothing mouthwashes, pain control, dietary changes like avoiding acidic foods, choosing softer textures is paramount to enabling the patient to eat enough.
And what about medications? Are there appetite stimulants?
There are, and that's something that requires careful consideration. Medications like mirtazapine, which is also an antidepressant, or magistral acetate, might be considered in some select cases. But providers have to carefully weigh the benefits against potential side effects. We mentioned sedation earlier, that's a risk.
Right.
And also the risk of blood clots, which is a significant concern, especially in older adults who might already be at higher risk. It's a complex decision, very patient-specific.
Okay. And shifting back to home, what about what you, the patient, and you, the caregiver, can do? Back to that mantra, make every bite count. What are some practical ways to do that?
Yeah, this is where the home environment really becomes an extension of the nutritional plan. And caregivers can be incredibly creative and helpful. A really powerful strategy is to fortify foods, subtly transforming everyday meals into calorie and protein powerhouses without making them seem overwhelming.
Fortify, like adding things in.
Exactly. Adding things like unsalted butter, olive oil, heavy cream, or even unflavored protein powder to common things. They might still be eating soups, oatmeal, mashed potatoes, smoothies. These additions often go unnoticed, or they just make the food taste richer, but they significantly boost the nutritional and caloric content, providing much-needed energy.
That's clever, sneaking in calories.
In a good way. And beyond the food itself, the mealtime environment plays a surprisingly big role. Creating a pleasant, calm, social atmosphere, free from pressure, can really improve intake. Forcing someone to eat, making mealtime a battle, it almost always backfires.
Creates more resistance.
Absolutely. Reduces their desire to eat even more. So, focus on small portions, offer choices, make it relaxed, enjoyable, even if it's just for a few bites. Sometimes just light conversation or soft music helps.
And that metallic taste, any tips for that?
Yes. A simple trick is using plastic utensils instead of metal ones. Sometimes that helps bypass the metallic sensation.
Oh, interesting.
Also, encouraging mouth rinses with a simple baking soda and salt solution, just mix it in water before eating, can sometimes cleanse the palate and make food taste a bit better, less offensive.
Okay, good practical tips.
But perhaps the most crucial point, honestly, is for caregivers to always respect the patient's preferences and aversions. If they suddenly hate a food they used to love, don't force it. The goal is consistent nutrition and calorie intake, not sticking to some rigid plan.
So flexibility is key.
Totally key. Sometimes, offering a favorite high-calorie food, even if it seems unhealthy, like a milkshake or ice cream, should be seen as a victory. If that's what they can get down and it provides calories, great.
Right, calories are calories at that point.
Exactly. It's contributing to their nutritional status, combating frailty. It's about meeting them where they are, ensuring they get some sustenance. This can be tough emotionally for caregivers who want them to eat healthy, but flexibility prevents power struggles and actually promotes intake.
An energy crisis.
Let's move on to another side effect that sounds incredibly pervasive and maybe profoundly misunderstood. Cancer-related fatigue, or CRF. This isn't just feeling tired, is it? It's cited as the most common and distressing side effect, affecting something like 90% or more of older adults in treatment.
That figure is astonishingly high, yes, over 90%. And you're right, it's absolutely not just feeling tired after a long day. We're talking about a profound, debilitating, persistent exhaustion that simply isn't relieved by rest or sleep.
So sleeping more doesn't fix it?
Not really. You could sleep for 12 hours and still wake up feeling utterly drained, like you've run a marathon overnight. It's an active process. The cancer itself and its treatment trigger inflammation and immune responses that create this massive metabolic energy drain that sleep just can't fully replenish.
It's more than just a symptom, then.
Much more. It severely impacts daily functioning, makes simple tasks feel insurmountable, and it drastically diminishes overall quality of life.
And why is it often worse in older adults? Is it that reserve issue again?
It often ties back to that, yes. Lower physiological reserves mean less metabolic buffer to begin with. Then you add the cumulative effect of comorbidities, other chronic conditions already draining energy, plus the profound strain of the cancer and its treatments.
It's a perfect storm for exhaustion.
It really is. And the wider implication is significant. CRF doesn't just make someone feel tired. It severely limits their participation in meaningful activities. Things like spending time with family, hobbies, managing personal care, even just conversation. This directly impacts their sense of self, their independence, their well-being. It can lead to real social isolation and a sense of loss.
Okay, so given how widespread and impactful this is, what are the first steps for providers when patients report this kind of energy crisis? How do you even start to manage it?
Well, the provider's first step is absolutely critical. They need to do a thorough workup to identify and treat any reversible contributors to the fatigue.
So it might not just be the cancer or treatment.
Exactly. It's crucial not to just dismiss it as cancer fatigue. There might be very treatable underlying causes that, if addressed, could significantly improve energy levels. This includes checking blood counts for anemia, very common cause of fatigue, and treating it if needed, maybe with transfusions or stimulating agents.
Okay.
Screening for hypothyroidism and underactive thyroid, which causes huge exhaustion. Screening for depression, which often goes hand in hand with cancer and tanks energy levels. Correcting any electrolyte imbalances, low sodium, low potassium. Those can cause weakness and fatigue too.
Makes sense. Rule out the other stuff first.
Definitely. And this brings us back to polypharmacy again. A meticulous review of the patient's entire medication list, every single prescription, over-the-counter, supplement, everything. Because many non-cancer drugs can contribute to sedation and fatigue. Sometimes a simple adjustment, a substitution, even just consolidating meds can make a world of difference.
And what about actual treatments for the fatigue itself?
Well, perhaps one of the most effective, yet often counterintuitive medical interventions is actually a formal referral to physical therapy.
Physical therapy? For fatigue? That sounds backward.
It does sound strange, right? Suggesting exercise when someone feels utterly drained. But a personalized, gentle exercise program, tailored specifically to their current energy levels and abilities, can actually combat the deconditioning that often makes fatigue worse.
The downward spiral of inactivity.
Precisely. It's about building stamina slowly, safely, preventing that muscle wasting. It might start with just a few minutes of gentle movement, but over time, it can significantly improve endurance and energy.
Okay, so for you, the patient, and your support system, what practical day-to-day steps can help manage this relentless energy drain?
Managing CRF is definitely a daily exercise in intentional energy conservation, and caregivers can be incredibly helpful here, implementing what we sometimes call the 4 Ps.
The 4 Ps. Okay, what are they?
First P is planning. Plan the day around energy peaks. Most people have times when they feel slightly better, morning, afternoon. Identify those windows and schedule essential activities then.
Got it. Plan around your best times.
Second P is prioritizing. Not everything can get done, and that has to be okay. Focus fiercely on what truly matters for well-being and function to pay. Maybe it's showering, eating, a short visit. Let the less critical stuff go.
Prioritize. Makes sense. What's next?
Third P is pacing. Deliberately alternate tasks with rest. Don't try to do everything at once. Break activities into smaller chunks. Rest in between. Instead of cleaning the whole kitchen, maybe just do the dishes, then rest, then wipe counters later, maybe.
Pace yourself. Okay, and the last P.
The fourth P is permission. Granting permission to delegate and ask for help. This is often the hardest one. Many older adults are fiercely independent, hate feeling like a burden.
Yeah, I can see that being tough.
But accepting help isn't weakness. It's a brilliant survival strategy. It preserves that precious, limited energy for what truly counts for them.
Plan, prioritize, pace, permission. Got it.
And the caregiver can also be a great walking buddy, encouraging short, slow walks. Even 10 minutes outdoors can help combat deconditioning, improve circulation, lift spirits, maybe even help sleep without overdoing it.
Gentle movement, not pushing too hard.
Exactly. And establishing good sleep hygiene is also vital. A regular sleep-wake schedule, even when exhaustion makes it hard to get up. A restful bedroom, dark, quiet, cool. Minimize screens before bed, avoid heavy meals late, basic stuff, but important.
Right.
And maybe stepping back for a second, accepting help from the wider community, friends, family, support groups, neighbors, is crucial to prevent caregiver burnout.
Protecting the caregiver too.
Absolutely. An exhausted, overwhelmed caregiver can't effectively support the patient. Letting others help with errands or meals frees up the primary caregiver's energy, which in turn helps preserve the patient's limited energy for meaningful activities. It strengthens the whole system. Neuropathy and gait impairment. The high stakes of a fall.
Okay, our last side effect has, as you said, really profound implications and exceptionally high stakes. Neuropathy and gait impairment. We're talking chemotherapy-induced Peripheral neuropathy, CIPN, that nerve damage from chemo, right?
That's right. It's a debilitating side effect from many common chemo agents, affecting a significant number of patients, maybe 30 to 70%, depending on the drugs used.
30 to 70%, that's a lot.
It is, and it typically shows up as numbness, tingling, burning pain, or weakness. Often starts in the fingers and toes, what we call a stocking glove pattern, and can progress up the limbs.
Now, how are the consequences magnified in older adults? You mentioned falls.
Yes, the consequences are profoundly magnified if we connect the dots. Older patients often have pre-existing neuropathy already, maybe from diabetes or vitamin deficiencies.
Okay, so they're starting behind.
Potentially, yes. Add to that age-related vision changes, which impact spatial awareness, maybe hearing loss, which can affect balance cues, and naturally slower reaction times. You put all that together with new chemo-induced numbness or weakness in the feet, it truly creates a perfect storm for falls.
A perfect storm. That sounds ominous.
And for a frail, older patient with cancer, a fall isn't just a minor event. It can be absolutely catastrophic, leading to maybe a devastating hip fracture, long hospitalization, a profound loss of independence, often irreversible.
And it could even stop their cancer treatment.
Tragically, yes. It could lead to an abrupt end to their vital cancer treatment. Their ability to continue chemo often hinges on staying mobile and avoiding major complications like a bad fall. This is why preventing falls isn't just important, it's paramount. The stakes are incredibly, undeniably high. It impacts their physical health, their independence, the whole trajectory of their cancer journey.
Wow, okay, so given these incredibly serious risks, what can providers do proactively? How do they get ahead of this before it leads to a fall? It sounds like they need an anticipatory stance.
It's absolutely non-negotiable. A proactive, anticipatory stance is essential. Before starting any neurotoxic chemotherapy agents known to cause nerve damage, providers should meticulously assess baseline fall risk and existing neurological function.
How do they do that?
It's not just a casual chat. There are simple, powerful tools. One common one is the timed up and go test, or TUG test.
And up and go.
Yeah, you time how long it takes the patient to stand up from a chair, walk about 10 feet, turn around, walk back, and sit down again. It gives a quick, objective snapshot of their balance, gait speed, mobility, helps identify issues before treatment starts.
Okay, a baseline measurement.
Exactly. And then continually monitoring for new or worsening symptoms at every single visit is crucial. Asking specifically, any new numbness, tingling, pain, weakness, changes in your balance, feeling unsteady.
Got it. Constant vigilance.
And critically important, providers must be prepared to reduce the chemo dose or sometimes even switch to a different agent if neuropathy starts to compromise function, safety, or quality of life.
It sounds like a tough call.
Yeah.
Balancing treatment effectiveness with safety.
It's a very difficult decision, but sometimes a slight dose reduction allows the patient to continue treatment safely and finish their course, whereas pushing through could lead to that irreversible fall that stops treatment altogether.
Right. Better to adjust than to have a catastrophe.
Precisely. And this is why a standard referral to both physical therapy, PT for balance training and strengthening, and occupational therapy, OT for a comprehensive home safety evaluation should really be considered standard for any older patient getting these neurotoxic dogs.
PT and OT.
Yeah. PT helps improve gait stability, core strength. OT identifies hazards in the home rugs, clutter, lighting, and suggests practical modifications to prevent falls. Make the environment safer. It's a vital, multidisciplinary approach.
Okay, this makes so much sense. And this is truly where the caregiver's role is not just important, but absolutely paramount again, isn't it? What are the most critical things a caregiver can do for fall prevention at home?
Indeed, the caregiver often becomes the primary advocate and really the safety officer within the home environment for this issue. It absolutely begins with a meticulous safety audit of the entire home, systematically going room by room, identifying potential hazards.
Like what specifically?
Number one, get rid of all throw rugs. They are notorious tripping hazards, even for people without neuropathy. Just remove them.
Okay, no throw rugs.
Clear all clutter from walkways. Ensure paths are wide, clear, unobstructed. Install nightlights, especially in hallways, bathrooms, bedrooms, for better visibility during those nighttime trips. Place non-slip mats in the tub and shower. And install grab bars near toilets and showers. These are fundamental, relatively inexpensive changes that drastically cut fall risk during routine activities.
Makes sense. Basic home safety upgrades.
Exactly. And on the patient's part, they need consistent encouragement to wear sturdy, supportive, closed-toe shoes all the time.
Not slippers or bare feet.
Definitely not. Loose slippers, flimsy sandals, bare feet, they significantly increase fall risk due to a lack of support and grip. Supportive shoes are key.
Okay.
The caregiver also has that incredibly crucial role in helping the patient overcome reluctance to use a prescribed cane or walker.
Because people resist them.
Many do, yes. They see them as a symbol of disability or weakness, but the caregiver needs to gently, consistently reinforce that these are tools for maintaining independence, mobility, and safety. They help preserve the ability to move around safely, which is central to quality of life. Not a symbol of decline, but a tool for staying independent longer.
That's a great way to frame it.
And finally, maybe the most critical piece. The patient and caregiver must form this unwavering pact, an agreement, to report any new numbness, tingling, weakness, or stumbling to the oncology team immediately, without delay.
Don't wait for the next appointment.
Absolutely not. If symptoms are new or worsening, call right away. Early intervention is critical here. If caught early enough, dose adjustments or medication changes can often happen before the neuropathy gets severe enough to cause irreversible nerve damage, or, crucially, that life-altering fall. It's about constant vigilance, open communication, and understanding that prompt action can truly make the difference.
Ouch. So, wrapping this all up, what does this deep dive really show us? Treating cancer in older adults, it's clearly a delicate, complex art, isn't it? It's so much more nuanced than just, hitting cancer cells with strong drugs.
And that's exactly right. It extends profoundly beyond just eradicating the malignant cells. It's truly about holistically preserving the whole person, their physical function, their cognitive clarity, their independence, their dignity, and ultimately their quality of life. By recognizing the heightened prevalence and the profound impact of these side effects in this often vulnerable population, care teams can and really must shift to this more holistic, person-centered model.
And it's not just theory, right? It's practical.
Absolutely. It's a practical, empathetic approach that demonstrably improves patient outcomes and their experiences. It allows them to truly live, not just survive, through their treatment.
Yeah.
And the real power, as we've discussed, lies in this remarkable synergy. It's the provider's clinical expertise, their proactive assessments, those crucial referrals to specialists like dietitians, PT, OT, combined with the caregiver's vigilant support, their practical assistance, their keen, compassionate observation at home. And importantly, the patient's own active participation, communicating symptoms honestly, sticking with the strategy.
It's a partnership.
It's a true integrated partnership. Everyone working collaboratively towards that common goal, maintaining well-being and maximizing potential throughout treatment.
So through this integrated, compassionate approach, older adults can better navigate these really formidable challenges of cancer therapy, preserving their strength and their spirit. Which maybe leaves you, the listener, with an important question to ponder this week. How can you or your loved ones proactively build this kind of collaborative, multifaceted team around you, maybe even before treatment begins? What concrete steps could you take to foster that open communication with your care team, identify potential caregivers, or start adapting your home environment? All to maximize the chances for a future that's defined not by the limitations of the treatment, but by the life it has afforded. Maybe consider what one practical step you might take this week, based on what we've shared today, to better prepare or support someone navigating these cancer treatment side effects. Thank you for diving deep with us.